reporting is in progress. We have the presentations very, very short because we really want to spend the time getting feedback from everyone. And so we're just going to briefly go through to level set on what the project objectives are, and then we have some discussion prompts to help you kind of frame your feedback back to us, but this will not be as heavily structured as the first meeting was if you attended that one. So Jillian, if you want to move to the next slide. So the purpose of the evaluation was to develop that system for establishing and maintaining rates that are sufficient to support and sustain the system and providers, and to evaluate managed care's rates and rate setting system to develop a plan for the creation of a comprehensive, streamlined, and coherent system. Go ahead and move to the next slide. There's a timeline where we have the November benchmarking report that came out right before Thanksgiving, and the provider member and listening sessions that have been scheduled, and then going forward, the interim findings in January and the final report in February, and the items that would be will be in those reports underneath it. Go ahead and move to the next slide. Thanks. So the meeting structure, sort of our rules for engagement, very similar to the last meeting if you were at that. But our role is to really ensure that participants keep their comments within the announced time limits. This is not a large meeting like some of the other ones, so we will be more flexible and won't set hard limits on responses. Right now, we're just going to ask people to be respectful of everyone who wants to speak and give people time. We'll also ask you to keep your comments to pertain to the topic under discussion, and we will be recording this to ensure all comments are captured accurately. We're asking you to introduce yourself, your organization, and the services you provide so we can make sure that we associate the comments to the right section. And if someone has said something you agree with, it's perfectly fine to say, I agree with that person's comments. And then, like I said, please just be respectful of giving everyone an opportunity to speak. So the purpose of today's meeting, since we have posted the comparison of the rates, it's to gather those additional points that you suggest for consideration regarding the rate comparisons, and the sufficiency of your current rates, and any issues related to rates that impact their access or sustainability, excuse me. Go ahead and move to the next. So in order to do that, we have some discussion prompts of things that are areas that might be helpful feedback, like are there assumptions or costs that are critical to consider that may be unique to Maine that wouldn't be reflected in another state's rate? Are there differences in payment methodology or services that could explain some differences in certain rates that it may not be evident from just looking at the fee schedule and service descriptions? And then are there services where current rates contribute to access or quality issues? And do those then impact other parts of the service system? So those are the types of feedback that we're looking for that to help us add more context and to help inform the recommendations in the priority list. So if you want to go ahead and raise your hand, or if you can't find the hand button, chat to us in the chat box, and Jillian will go ahead and start going through the list to unmute.
Okay, first up, I've got Jeffrey.
Hi, good morning. Can you hear me?
Yes, we can.
Okay, my name is Jeff Wallwender. I'm the Executive Director, Chief Dental Officer, and a full-time frontline dentist for Community Dental. We have centers in Biddeford, Farmington, Rumford, and Monson. I'm on the board of directors for Northeast Delta Dental, one of New England's largest dental insurance companies, so I'm very familiar with rate setting. So first, I just wanted to really thank Michelle and her department for the difficult work they do, expanding Medicaid and carrying the work that it is really Michelle is on. I wanted to start off with just things. I just wanted to kind of say that there's a few mistakes that are noted, and then I think the methodology for how you've calculated the commercial insurance is very wrong. And I'll point out why, and I'll use plenty of examples here. So first off, there's a few codes. So if you look at child prophy and sealants, I think there's a translational problem here because you're listing the median fee as $147 and $576 respectively, and that is not even close to what it would be. They're typically much less than that. So I think there was some kind of translational problem that you had there. So that's that. But as far as the methodology, you're treating commercial dental insurance as if it were medical insurance, and there's a world of difference between the two of them. So in the description of the APCD data you're using on your spreadsheet, it leads me to believe that you're using the paid amount, while the numbers that should be utilized are submitted amounts. So if it is in fact the paid amount, we would expect the numbers to be much lower for commercial payers in categories other than diagnostic and preventive, where more often than not, copays and deductibles come into play here. So in any case, the situation is far worse than you're kind of letting on for main care providers. And I'm going to use two examples, utilizing fair health data benchmarking and then Delta Dental PPO to highlight my point here. So if we look at code D2930, the median fee from the APCD data is $83. The Delta Dental PPO fee, which is lesser of the commercial insurance in the state of Maine, cost-wise is $217. The fair health benchmarking weighted average is $262, and the main care reimbursed fee is $120. So the data here of 83 is clearly wrong. And to just another fee, and I've done 30 of these. I didn't have time to do them all, but if we look at D3120, indirect pulp cap, the main reimbursed fee is $19. The APCD data is saying $26 median. Whereas if you look at the insurance companies on their fee schedules, the Delta Dental PPO fee is $64. The fair health benchmarking for the zip codes in Maine is $74. I'm happy to share this spreadsheet with the top 30 codes to highlight this point. I'm happy to do them all. I've already done a detailed comparison of main care rates compared to Mass Health, Vermont Main Care, dental schools, PPO insurance in Maine, Premier. I just want to point out that if we're utilizing Northeast Delta Dental's PPO fee schedule, right, which is the most widely accepted insurance in Maine, New Hampshire, Vermont, middle of the road, we're going to look at that 47 codes are above 50% of the PPO rate, right? 185 codes in main care are below 50% of the reimbursement of the PPO rate. But of those 47 codes that are above 50% of the PPO rate, 32 of them are typical for specialists only. So for example, a general dentist seeing patients age 8 to 100, only 15 codes are above 50% of the commercial PPO rate, many of them falling in the 30% category. I think something got lost in translation with the data that you're using. I'm happy to go code by code, but I just want to say also that in some of the codes that main care is paying us for, the lab cost alone of what we have to pay another service for the procedure is larger than what we're getting from that lab cost. So, and that doesn't even take into account, we have to pay the dentist, the assistant, our front desk, shipping, and supplies, let alone our lab bill is higher for the fee than what we're getting. I just wanted to add that. I have more to say, but I don't want to take up time without letting other people talk. I just wanted to really make sure while Michelle was here that there's nothing wrong with the methodology for the commercial rates, not for the other Medicaids. That's a great comparison. I think they did a really good job with that. We'll just mention that New Hampshire rates, I do believe that they're to raise them. While banned Medicaid, they had bipartisan support for it. I don't know if what's happening now with the pandemic, I think it's on hold, but there was also talks that they knew they needed to raise the rates there as well. Once again, I really appreciate your time. I have a little bit more to say, but I don't want to take up too much of your time. Thank you.
Okay, thank you, Jeff. And again, if you want to supply that spreadsheet for us to take a look at, the email address is here on the screen now. Next up, I've got Brian Hoops.
Hi, how are you? That was an interesting comment from the previous person. I'm interested in the fee for endodontics.
I'm sorry, Julian,
Specifically.
I apologize for bumping in, but Julian, I think we need you to mute. There we go. We're getting a lot of feedback. I just wanted to make sure everyone can hear. Thanks.
Hi, can you guys hear me? Okay, so the problem I have is I do a lot of endodontics. I'm a general dentist. Medicaid, the main care fee is quite low, and I get referrals from other general dentists and in Washington County, and I'm not going to be able to continue doing Medicaid or main care endo because the cost of my materials and time is more than what I get paid. I've been doing this I've been here for over 30 years, and I do a lot of it, and I can't continue to lose money on it. I don't know where you got your figures from, that endodontics are 46.1% of other fees, but in comparison, but that's not true. So that's pretty much what I wanted to talk about. You know, some of the other fees I could talk about too, but the endo fee specifically are ridiculously low. They haven't been raised in 25 years, at least that I know of. So I'm going to have to stop taking it if the fees aren't raised. Because while I'm willing to do something for free, I'm not willing to pay to do it. I just can't afford it anymore. Thank you.
Okay, thank you, Brian. Let's see, I'm not seeing any more hands raised. Let me check the chat. I'm seeing some agreements on the fees being off for dentures. And let's see. I have one hand raised back to Jeff.
Sorry if no one else is gonna talk, but I just wanted to kind of go more over. That was a little bit of the objective things for the data. I just want to go over a few subjective things, and I will echo Dr. Bryan's statement there as far as endo, that it certainly is one of the lower ones on the fee schedule there. And it isn't sustainable, but I just want to kind of mention that, especially for the nonprofit clinics bearing the largest burden, you know, we're the area that have the largest payer mix of main care. And a lot of these areas are no longer eligible for loan repayment. So it's bringing the situation to a more catastrophic level. You know, for example, in the Biddeford area, it's certainly not eligible for loan repayment because of the amount of dentists, but our payer mix in that area is over 50%. And if you are losing money on 50% of the procedures you do, it's a recipe for disaster. And I think part of the reason for this review today is to evaluate the viability of the provider network. And I can tell you in full disclosure that Community Dental has been actively evaluating the closure of our centers that lose the most money. Without the pandemic, we would have been looking at closing 1 to 2 centers in 2020. And the other four starting to place restrictions on the amount of main care recipients we would be able to take. And that is one of the last things in the world I want to do, against everything I believe in and stand for. And I've worked incredibly hard to prevent this from happening. We've cut every possible costs we could find. I'm an open book. I would be happy to share all of our financial details on how devastating cuts in funding and main care rates have been to us for the last 10 years. You know, and without help in the near horizon, 2021 for community dental is going to go back to our 2020 game plan. And I just want to kind of point out that the cost of starting a new 12 ambulatory dental clinic initial cost is going to be over $1 million to fit out and equipment purchases. And this doesn't include the first year, which almost certainly the clinic will have an operational loss. The cost to maintain your provider network is considerably less in the short and long term. And I can tell you, as someone who's on an insurance company board, one of the most valuable and important assets is your provider network. So, and one other thing that I just read the other day is the AA's Health Policy Institute's been tracking trends since the pandemic shutdown. And in their September 2020 edition, they reported that 6% Medicaid providers and private practices disenrolled since the start of the pandemic, and an additional 16 are considering disenrollment by the end of the year. You know, as private practices stop taking, you know, main care like Dr. Brian, these patients have to go somewhere and it ends up going to the nonprofit, and that further reduces our payer mix of private pay patients at the loss. You know, the higher you get, and I can make specific examples from our centers and provide the data, that the higher you get with that, the worse off you are, unfortunately. So once again, sorry for talking too long. I do want to let other people chime in, but that's just kind of some of the subjective data that I see, and that I really do appreciate this rate setting. And this is the first time we've had a chance to ever talk about it. I go to all of the main care advisory meetings, and they tell us that that's not the place to talk about rates, and we don't. This is our opportunity and prevent disaster here with the provider network.
Okay, thank you, Jeff. Let me see. Next, I have Angela Westhoff.
Yes. Hi, can you hear me?
Yes, we can.
Okay, great. So my name is Angela Westhoff. I'm the executive director of the Maine Dental Association, and I just want to start out by thanking Maine Care and the consultants for the opportunity to comment and for engaging in this important work. I echo Dr. Wallwender and Dr. Hoop's comments that it's very much appreciated. By way of some background, the MDA represents 90% of Maine's licensed dentists, and we're very pleased to be part of this conversation. I just wanted to share that we recently did an informal survey of our members. So that survey went out to 765 dentists in Maine. We asked questions about a number of topics. We received over 230 responses, so that represents an approximate response rate of about 30%. In that membership survey, we specifically asked members about their participation in Maine Care. 41% of those who responded to the survey said that they are currently participating Maine Care providers. Of the 59% who responded that they do not accept Maine Care in the office, the number one reason cited was low reimbursement rates. That was followed by administrative burdens, and third was a high no-show rate. Some of the written comments that I pulled, and I just pulled a few, trying to be respectful of time, but I think that they're representative and should be shared. The first comment is, the paperwork is onerous and the no-show rate is high. I choose to do pro bono work instead. Difficult repayment. I lose time and money, and there are frequent no-shows. I have not treated patients with Maine Care due to the low reimbursement rate here in Maine. The state I moved from had significantly higher reimbursement for Medicaid, and I did take patients there. And then the last comment I wanted to highlight was, this dentist wrote, I feel super sad and frustrated about not being able to afford to provide services to Maine Care patients, but the numbers just don't add up. A common theme here is that dentists want to be able to treat all patients. However, they do have a business to run, and overhead in a dental office is very high. Also, if the paperwork is onerous and is a barrier to participation, I think we're doing a disservice to patients. One example that's already been mentioned, but I think it's worth highlighting again, are dentures. So main care reimbursement rate is very low. I think it's somewhere on average of $350 or $380. That doesn't even cover the lab fees to make the denture. Patients are often left in pain and with a poor quality of life because they can't even chew the food that they need to eat. Beyond the low reimbursement rate, another problem is red tape. So a physician has to sign off on a form indicating that the dentures are medically necessary. And one dentist has told me on more than one occasion that due to failed attempts to reach a patient's primary care provider, he ended up driving across town to demand getting a signature on a form. In my mind, that doesn't make any sense. I think we have to look at a comprehensive change in the system. We have to focus more on prevention and diagnostics, which these very detailed spreadsheets show are among the lowest percentage of comparison rates with other states. Main care reimbursement rates remain at less than 50% of commercial dental insurance reimbursement rates by and large. And others have echoed that dental rates haven't been increased in a very long time, so they've remained stagnant for decades. Unfortunately, these low reimbursement rates threaten the viability of the safety net dental clinics and oftentimes undermine the ability of private practice dentists to treat significant numbers of main care patients. We all know that dental care is critically important to one's overall physical, mental, and emotional well-being, and without the financial resources to pay for treatment, patients often resort to emergency rooms to seek relief for oral pain and infection, and the cost to the system is exponentially higher. I think we need to focus on prevention and diagnostics and restorative dental services and have a program that's comprehensive for children and adults throughout Maine. Thanks for the opportunity to comment. I appreciate your time.
Okay, thank you, Angela. Next up, I've got Carly. Oh, sorry. Heidi needs to talk to you. Let me find that person. Heidi for Carly.
Okay. Can you hear us?
Yes.
Okay. I think we want to start out by just echoing what everybody else has said. We are an ambulatory surgical center in northern Maine. Our rates are, besides the dental rates, the facility rates are where we're heading with this discussion. And I don't know if you want to do that now or after the dentists have talked.
So we are focusing on dental specifically for this and not the ambulatory surgery, but I think that there's enough time to go ahead and just list all your comments here and we'll note it.
Well, I do believe on the first part of the meeting did say ambulatory surgical oral surgeons, unless I...
No, I mean, I think it's fine to go ahead with all your comments here.
Okay. Well, we are in the same boat as everyone else. The reimbursement rates are terrible. The lack of support that we're getting, we're trying to accommodate all the patients here in northern Maine. We're actually getting patients as far south as southern Maine. They're all coming up here because we are taking Maine care. And I think we're pretty much the only oral surgeon in the state of Maine that's taking Maine care right now that doesn't have a 3-year waiting list. On top of that, we have an ambulatory surgical center. Our reimbursement rate for the facility for the removal of impacted teeth is way below any other state in the United States. When we look at ASC reimbursement rates for procedures of similar time and skill, an oral surgeon is similar to the removal of 4 wisdom teeth is similar to a carpal tunnel surgery. They're getting $781 according to Medicare guidelines. Cataract surgeries are at $977, all very similar to what an oral surgeon does when he does wisdom teeth. Circumcisions of the newborn babies, $785. We're getting $176.35 in our surgery center. If you look back on the Medicare reimbursement rate, dental procedures are excluded from Medicare. So when we opened this surgery center 10 years ago, we got a rate. That rate was $176.35. nobody has been able to give us any guidance as to where that figure came from. We've got cost examples associated with having an ambulatory surgical center for an oral surgeon. We have licensure fees, state licensing fees, credentialing fees, equipment inspection, repairs, and testings, all come to the tune of $30,000 to $50,000 a year for being an ambulatory surgical center owned by an oral surgeon. Throw in the professional fees that are far below standards. We're not going to be able to do it anymore. We are looking at having to restrict our main care. And I do thank you for your time.
Okay, thank you. Next up, I've got Becca.
Hi, thank you. This is Becca Matisovich with the Partnership for Children's Oral Health. And I was unable to get the login to work at first, so I'm on the phone. Can you hear me okay?
Yes, we can.
Okay, great, thank you. Yeah, I want to second a lot of the comments that I've heard so far joining late, and to really thank you for the detail that's provided in these workbooks. I haven't had time to, really go through every level of detail in them yet, but it's a huge amount of information, and I really appreciate the transparency of sharing all this information, because I think it's an opportunity to really have the right conversation that needs to be had. And we've been pretty desperate to get some attention that this issue is as dire as you are hearing here today. So what I can say so far is that, it's pretty overwhelming to see all the codes on all the tabs. And so I actually went through the workbook last night and sort of pulled out 3 categories that our partnership, which is a network of a whole variety of different players who are concerned about children's oral health, are focused on. And so I have 3 sort of subsets that I've looked at across to pull together a set of codes across the different tabs that we would consider maybe routine care, with some of the priorities that we're tackling, looking at access for main care children. One of those categories is oral health services in primary care settings. One of them is school-based preventive care. And one of them is just a routine basic care in a dental office, like being a dental home for kids getting routine care. And it's sort of too much detail to just share in my comments. I'm happy to forward those subsets and what I can see in the spreadsheet for those, as well as some of what I know I've been hearing from both the community and from the providers about some of the barriers for the codes in each of those categories. So I will send that along with written comments, but I just want to say that the overall takeaway for me in looking at it that way was that, there's really only a handful of codes that make up the basic core of routine services for maintaining good oral health in a preventive way. And virtually all of them are well under the comparison states rates, and rarely do they break out of the 25th percentile of commercial rates. There's only one exception really, and that's the silver diamine fluoride, which just got added last year. So it's not surprising to me at all what you're hearing from Jeff and some of the other providers, which I've also been hearing from basically all of the safety net providers that are out there, that the business model, just doesn't work. And it doesn't even work for nonprofit organizations to provide routine dental home services or for school-based prevention programs to reach kids where they are. Financially, it just doesn't work. And therefore, it's not surprising that we have a limited supply of providers who can provide this kind of routine basic care for the main care population that most of us take for granted. And they're only able to do it by relying on sort of volunteer angels who donate a lot of their time, grants, and fundraising every year to make up their budget gaps. And as a result, instead of just paying providers sufficiently to cover the cost of providing preventive care and early intervention, instead we end up spending more than should be necessary on emergency care. And now we're really seeing that access to care for urgent needs is now so limited that people are facing, years of waits, as you just heard, for referral to an oral surgeon for problems that could have been dealt with much sooner if things were structured differently. And all of that was true before COVID even hit. But now, with the reduced patient volume, increased costs, the unpredictability of sort of staffing, as well as patients' ability to come to the office on a daily basis because of exposures and quarantines and everything else, staffing challenges, that's pushed the situation to the breaking point. And the safety net providers who are persisting day in and day out to try to meet the oral health care needs of our population are stretched so thin and facing revenue shortfalls that they may have to cut staff if their finances aren't stabilized, or close centers, as you've heard Jeff say. And these providers can't wait for a long-term solution to come through a rate setting process that will take several years. So while I think this is incredibly important for the long-term solution, I really want to stress that we have kids whose teeth are literally deteriorating in their mouths right now, and we have pediatricians who are searching for a dentist to refer kids to for that kind of dire situation and can't find one. And all of that, I guess I was really interested also to look at the spending. I just pulled a couple things I thought might be kind of canary in the gold mine indicators, and saw that, MaineCare spent over $1 million on prefabricated crowns for primary teeth last year, almost 8,000 crowns for primary teeth. That seems to me like a service that, that should be rare, I think. I'm not a clinical provider, but I'm pretty sure that's not something we would consider routine care. We spent over $3 million to extract almost 34,000 teeth. And that doesn't even include impacted extractions, since I think those are probably less likely to be preventable. But in comparison, we spent less than, or just over maybe $1.5 million on sealants and fluoride varnish, which are two of the services with the most evidence behind them to prevent decay. So I think things are just a little bit out of whack that way. And I just thank you for the opportunity to draw attention to that.
Okay, thank you, Becca. Next up, I have Norma.
Hello.
Hello,
Hi.
yes, we can hear you.
My name is Norma Desjardins. I'm a general dentist, and I'm the executive director of St. Apollonia Dental Clinic in Presque Isle. Can you hear me all right?
Yes, we can.
So at St. Apollonia Dental Clinic, we provide comprehensive dental care for children, mainly from 0 to 21 years old, and special needs kids and adults older than that. We have about 75% of our patient population has MaineCare. And I'd like to also thank you for the opportunity to speak today and for all the work that's been done in gathering this information. And I'd also like to say that I have a background of about 26 years in private practice, while I was towards the end of that career developing the St. Apollonia Dental Clinic and founding it as a nonprofit. I had seen over the course of my private practice career that MaineCare just doesn't work in private practice. And I'm also finding that it doesn't work in the nonprofit world either. It's just really difficult to make ends meet with the low level of reimbursement. And all of the examples that have been given today are really good examples of what we're experiencing. And some providers won't even be in this process because they're just too frustrated with the whole thing. Over the years, there have been many times when we've tried to address the issue, and the results and the reimbursement rate is, in some people's eyes, is seen as laughable. You know, it's just not, you can't do it. So how does this affect the patients? Well, for example, there are providers who are trying to recruit more providers either into their practice or into the state. And one of the first questions that new providers ask, especially in private practices, is how much main care do you see, or how much Medicaid do you do? And if it's above even a certain small amount, they don't even want to look at that practice as a possibility to work there because they know that the reimbursement is so low. That's just one example. Another example that I want to give as far as onerous paperwork, there's many examples of what our clerical staff has to deal with as far as main care paperwork. So for example, why do we need a prior authorization for a 3-month checkup, which is, you know, fluoride varnish, extra oral hygiene instruction for kids that we already know are at high risk? So if we try to do, if we're already doing Carrie's risk assessment and we know what their score is and they're at high risk, they should automatically qualify for the additional services, the additional preventive services. And what's happening is we have to, you know, there's paperwork that's required. So sometimes we're paying for clerical paperwork, we're paying somebody to do that when we should just be putting that money directly into the mouths of the kids, directly into the fluoride varnishes that they need, or the additional instruction or the additional prophies. That's one example. There are patients whose circumstances put them at higher risk, and there are those who are at lower risk. Maybe we need to look at a system that pays for more preventive and smaller restorative services for those who need more, and just the right amount for those who are considered low risk. So for example, the kid who is low risk needs the 6-month checkups, maybe doesn't need more, and the kid that's high risk does need more. I'm imagining that if main care goes through this process, is taking the time to go through this process, and there is any kind of rate increase, there will also be an expected increase in value. How will more money spent equal better service delivery for main care members and better outcomes? How are current outcomes measured? If we look to the future and consider some sort of value-based purchasing or an alternative payment system, which includes features of both current and future systems, what does that look like? So if that's the goal, then I really believe that providers, we dentists of all ranges, specialists and general dentists, will have to be included in discussions of how this is to be developed. Otherwise, there's no true collaboration. As it is now, I kind of feel like we're in the dark, but maybe I speak prematurely. Maybe it's too early in this process yet. But in the past, when I've attended main care dental advisory meetings, it sometimes seems like the information is given just slowly and metered out. Why can't we know more of the story and actually participate in this plan for the future, perhaps? As far as what I think it was Dr. Bryan at the beginning said about endo, it's so true. Endo is a procedure that saves teeth. And what happens is that it's reimbursed at such a low rate that it's not happening. Maybe it's not being recommended, or I'm not sure, but I know that you can't do the procedure at what's being reimbursed and still make it. I agree totally with what's been said. And so what happens with those teeth that would have needed endo? They end up being extracted. Those are the realities for main care patients. And with conversations with my colleagues up here who are dealing with this regularly, and it is in our face, people asking for help with their neglected teeth, their poorly cared for teeth for whatever reason. and their options are minimal. I think if we were able to diagnose, put more money into diagnosis and prevention, we definitely could serve members better. And so if the system is currently broken, which I think it is, some have asked me, why are we inviting more into this system? Some have asked me, why do we want to include more adult services into a broken system? Maybe we want to be really addressing the system prior to that. Thanks so much for the time. I'm going to just say that we're doing our best to participate in these efforts, and we do hope that there will be improvements. Thanks.
Okay, thank you, Norma. Next up, I've got Barbara.
Yes, hi. Can you hear me okay?
Yes, we can.
Okay. So I am Barbara Covey. I'm an emergency department physician, and as a result of that and seeing the terrible oral health problems and disease that were coming through the emergency departments, I teamed up with a grassroots group that founded the Waterville Community Dental Center, a nonprofit dental center 21 years ago. I would like to say that I've seen, you know, I was naive in thinking that if we established this, we would solve all the problems of the area in short term, but I was very naive. And one of the severe problems we have is the reimbursement rate from main care. We currently see 4,500 patients in our center, 60% of whom are main care, 15% are sliding fee. This is the first comprehensive evaluation of main care reimbursement for dental services since before we founded our center. And there's been no significant across-the-board readjustment of services for decades. So I want to say with others that I really appreciate the process that we're going through now, and thank you for this work. It is so seriously needed. I'm going to try to just summarize some key points because I know there's been a lot of input and there will be more. But overall, I think the numbers clearly show that on the whole, my subjective sense that repayment has been inadequate to cover our services is shown objectively in the numbers that have come out in the comparisons in the data that has been provided here. And that basically I have a strong feeling that access to essential medical care should not be reliant on a system that depends on volunteers, grants, or budgets that are built on the backs of underpaid and overworked providers, which is what we have now. When we first started our center, we had the advantage of the loan repayment program, which Jeff Wallwender had spoken to. And for those who don't understand the implications, we could provide a lower salary to dentists relatively because they were getting some loan repayment, but those options are no longer available. So we have less and less reimbursement for higher and higher expenses, both because of overhead increase and increase in our cost of personnel in order to be able to recruit staff to deliver our care. And I would agree with Becca and others that, especially those fees that cover the basic routine preventive care for maintaining oral health are well under the rates that they should and need to be to cover expense and to be comparable to other rates. And the consequence is a higher rate of poor oral health and more expensive emergency and restorative care. And I can say from the experiences that led me to this work in the first place that those thousands upon thousands of emergency room visits for oral health emergencies where the money goes down the drain for temporary antibiotics and no definitive care is not the way to go, but we really need to focus on preventive care. I would also agree with Becca that the need is acute, especially in the presence of the pandemic. The rate system evaluation is critical and very appreciated. As a long-term solution, it's going to be very important, but there's also going to be the critical need for short-term solutions, such as the incentive payments that are currently in place, but only through December, if centers like ours are going to be able to continue to deliver the care that's needed. And I guess that sums it up for me. Thank you.
Thank you, Barbara. Next up, I've got Beth Pierce.
Hi, can you hear me okay?
Yes, we can.
My name is Beth Pierce, and I am the Oral Health Coordinator for the Maine Primary Care Association, but I also have a history as the EPSDT Coordinator and Provider Relations Specialist with the dental policy, as well as working in practices. So what I would like to tag on is what Dr. Covey had to say, which is, the temporary incentive payment that has been authorized through the pandemic. I would like to really suggest that in the current discussions that are taking place with value-based payment and care, patient-centered care, and all the comments that have been brought forward today about preventative in dental, that Maine Care entertain discussions with the group that you see today, as well as other stakeholders, about what that means in oral health. Oral health is primary care. And I think that oral health providers need to be considered as far as their maintenance of a dental home and patients within that dental home, and whether that equates to some other methods that are offered with your primary care providers, such as PCCM and various other things, where these providers are incentivized for maintaining and improving the health of their patient list. So I heard a couple other comments earlier kind of in that. Certainly preventative health and preventative care and oral health has been commented on heavily. The other issue is the burden, the administrative burden to request prior authorizations and involved other healthcare providers, when in essence, you're saying to the dental providers, your decision on the medical necessity of this procedure is not adequate. You need to supplement it with something else. That has been offensive in my experience working with dental providers, and I understand that. They are qualified to make some of these diagnoses and recommend that treatment, but they have been burdened by requesting authorizations for it. The other thing that I would like to point out is that if more focus was on preventative and reward and just opening up benefits to those who need it, the caries risk assessment codes are key. And that is something, when I was still working for Maine Care, I questioned as to whether they could be opened. Remove the barriers and allow those who need more frequent services to get them without the administrative burden of requesting a prior authorization and justifying that. So that's my position. Granted, I work with the Primary Care Association, so we do support the FQHCs, and their situation is a bit different. But I do encourage the department outreaching the stakeholders that you see here, as well as others, to have some of those conversations about what exactly is needed for change in the dental policy, reimbursement, and care delivery. Thank you.
Okay, thank you, Beth. Let's see. If you had your hand raised and your comment is complete, if you could lower your hand, that'll let me know whether you have finished speaking or if potentially you want to speak again or have another comment. Okay, I'm seeing hands lowered. And it looks like got another comment from Norma.
Hi again. I really completely agree with what's been said so far, and I just want to add a little bit of, I guess you could consider subjective. As dental professionals, we have ethical obligations to adhere to as we provide quality oral health care for the citizens of Maine, and I take this seriously, as do my colleagues. I hope you understand me when I say being a Maine Care provider and practicing according to the Maine Care contract often makes this hard to do. It's been a big reason why providers opt out of seeing Maine Care patients. It's not just the money and the reimbursement. It's about being asked to practice in a different way. We don't want to practice in a way that makes us question our training and our ethics, for sure. And that's partly why Dr. Hoops, I don't know, but he's done so much endo, like he said. What happens is we have colleagues referring to us to do some work simply based on the fact that we accept Maine Care. And so this would be another discussion, it's not for today, about why I feel this way. But it's also about, I agree with Beth, the respect given, and as far as having to obtain prior auths for things that really should be under our discretion and decision to do. When you look at only the numbers and what seems like a bottomless bubbling cauldron of percentages, statistics, stats, data, percentages, comparison rates, and more comparisons, and all these numbers, they're only a small part of the ingredients in this Maine Care stew. Keep in mind that even if reimbursement is compared with commercial insurance rates, it can't be forgotten that those rates have co-pays that can be collected from the patient, which is not the case with Maine Care. And that's what Jeff was talking about earlier. Reviewing rates of covered codes and opening codes and calculating percentages is important. And more importantly, there are teeth, mouths, and heads attached to those codes. There are moms like Shelley M. bringing 3 kids to their dental appointments when she's had to rearrange her whole work schedule months ahead of time, but she gets them there. And there are great grandparents and great-grandparents, I'm thinking of Mr. Philip D., driving an hour each way to make it to his great-grandchild's checkups or filling appointments while managing his own medical appointments. You all know the stories because you also live them, just perhaps with different specifics. Maybe you finally have a reliable car in your life and enough money to put in a full tank every time you fuel up. So these are the things that when our patients come in as Maine Care patients, there are so many things that they are dealing with. And we often spend so much time with them that's beyond what's coded and what's charged out. We're giving them resources. We're talking about how you can get to your appointment with Logisticare, helping them find that resource. We're helping them through so much more and spending a lot of time with them. And the Maine Care reimbursement just doesn't touch any of it. Thanks again.
Okay, thank you, Norma. Next, I've got Jeff again.
Hopefully this will be the last time for your sakes that you hear from me. Just a few other additional points here. I just want to kind of anecdotally say that, at Community Dental, with 6 dental centers, we don't even have a single manager at any of our clinics anymore. We don't have enough assistants. We don't have enough front desk to answer the phones. And we're the ones who have to explain the Maine Care benefit to patients that's complex. And, we're serving as the intermediary as well. And that's something that's not reimbursed. And to explain that to patients who have no idea is not easy. Another thing is on here is, when you say that, are these issues impacting other parts of the service system? And, one of the areas that, we see at Community Dental a lot of times is patients need immediate clearance for things like oncology treatment. People with cancer who have poor oral dentitions need dental clearance before they get started. And, you know, with the waits at oral surgeons, you know, we're the ones still making the time for these patients. And like I said, that it's being affected. There's wait times in order to get chemo and radiation because there's wait times at the dental office. And that's just not good. And as your provider network shrinks, or if a nonprofit closes, you're going to see that, you know, exponentially increase. Just another point is that, you know, when you compare this to other services, the dental overhead is incredibly high compared to other services. We can't just have an empty room and treat patients. We just can't do that. You need so much equipment that needs to be serviced. The cost of these servicing has gone up every year since I've been here. The cost of the equipment goes up, and we don't get big government discounts for that as nonprofits. We get a very minimal discount compared to private practice. And lastly, I think the data shows that, but we're being reimbursed at a fraction of what other Medicaids are paying. But the worst part of this has been going on for so long that it's been piling up, where loans for nonprofit clinics get higher and higher. You know, we have to take out a loan to repair a piece of equipment, and that we have to pay that back at some point. And it's an issue, but it's an issue that's been going on for so long that it's compounding. And that's why we need this to be addressed. And, you know, I really think that we should be at 100% of what the comparable rates of other Medicaids are. I don't think we need to be high, but we certainly can't, you know, when you're only marking fees that are below 40% or 50% of what another Medicaid pays, that's bad. That's really bad. So I really hope that you guys take a deep dive at this. If you need any help, you know, comparing the data for the commercial side, I'm happy to provide you with plenty of information. I'm sure Northeast Delta Dental would be happy to volunteer their time and give you additional information on averages for the states in Maine, New Hampshire, and Vermont. And hopefully this will be the last you hear from me. Thank you, thank you, thank you.
Okay, thank you, Jeff. Next I have Becca.
Sorry. This is Becca Matisovich from the Partnership for Children's Oral Health again. I know now we're going on like the second round. I just wanted to add that, you know, you're getting, I think, a lot of pent up sort of angst and frustration here today, and it's about a lot more than the rates, as you're hearing. And so I just wanted to make the point that I think everybody who's here and many others that I know are really excited and anxious to work on the solutions to these problems, and the solutions go beyond the rates. And we have efforts underway, collaborations underway, you know, trying to figure some of this stuff out. And in many cases, the key partner who's missing from the table in those conversations is often main care. And so we would really love to, you know, to get more engaged together with main care and work on these solutions. And we're happy to help sort of support those connections. Because we know the state also is suffering from, you know, limited capacity and many years of pent up sort of reductions in funding as well. So I think together we can do a lot more than we can separately, and we just want to offer whatever we can do to help with that.
Thank you, Becca. Okay, I'm not seeing any new hands or anything in the chat. Julia?
Okay, great. Thank you everyone who spoke up and gave comments. We truly appreciate it. We wanted to put the email up again. If you have specific written comments, please don't hesitate to send it to ratesettingeval@maine.gov. We're going to look into the few comments on the commercial ways to see what is in the database that's being reported. So we will absolutely look into that. If you have anything else you'd like to send us, please don't hesitate to do so. We want to make sure that it's a meaningful comparison for everyone. Thank you again for spending your lunch hour with us. We really appreciate it. And we hope to hear from you guys in writing. Thank you so much. Have a good rest of your day.